Good afternoon. Today I'm talking about the principles of increasing milk volume, and the reason I'm doing this as a subject on its own is because of the number of questions that are asked of me regarding increasing milk volume or low milk volume, or people believing that they start off with good milk volume and then they end up with low milk volume. So I thought maybe it was worth doing something that covered as much as I can in this particular session. So the principles involve stimulation of hormone from your pituitary gland, and I've probably said this so many times now you may be sick of it, I don't know, but I repeat it all the time, because once you understand the principles of how human milk is produced, then it's much easier to be able to work it. Our pituitary gland in the base of our brain, in the female brain, produces the hormones for both our ovary function, our hormonal function for ovulation and menstruation, and then when you're pregnant, they're suppressed, and the hormones prolactin and they gradually change. There's a transition goes on from pregnancy, and you have increasing prolactin and oxytocin into your bloodstream. And the way, once the baby's born, there's a whole flourish of hormone release, and then that continues when the placenta's born, and then that continues particularly for the next 72 hours till the milk volume peaks. So it's really important to go back to when the very first feed starts. So if you understand that the very first feed, generally under circumstances where you've got a healthy baby and you don't need any intervention, the baby makes its way to your breast in good time with you, with a minimum of handling, preferably no handling by anybody else. And then at that time your hormones are really flourishing. So then when the baby comes to the breast and finally starts drawing and swallowing, or starts stimulating hormone production and then drawing and swallowing, you get an increase of prolactin and oxytocin into your bloodstream. So the prolactin generates and makes milk and keeps the production up, and the oxytocin brings the milk and contracts it down through the ductal network so that it sprays out the end of the nipple over the back of the baby's throat. So they both work in harmony together, and at the same time oxytocin contracts your uterus, so it reduces bleeding postpartum, and you have to have some bleeding postpartum, but it reduces heavy bleeding postpartum, and so you'll feel your uterus contracting, and in the early days of breastfeeding you'll feel your uterus contracting, and sometimes it'll take your breath away because it's you feel that really tight contraction, but it's meant to be there. So the hormones are absolutely necessary for milk production and breastfeeding your baby, and then for maintaining milk production over time as well. So the first feed generally lasts about 2 to 3 hours leisurely. Now that's in my experience, comparing my hospital experience to my home birth experience over 25 years, where there was more pace in getting women through and in and out, and not as much as there is now in those days. And you were in hospital for 10 days in my time, but now you're in and out within sometimes 4 hours. So it's a huge difference in what happens. But it's really important not to interrupt or disturb that very first breastfeed, because the baby is transitioning from in the uterus now, sucking fingers, sucking hands, sometimes sucking thumb, drinking the liquor, the water around the baby, and then now transitioning to coming to the breast, drawing the nipple and some breast tissue to a unique teat shape in the baby's mouth. So the soft, pliable breast tissue becomes a unique teat. There's nothing else like it for your particular baby. And then the baby feeds leisurely on and off both breasts, stops to look at you. I've got some beautiful video clips of little babies just born, and they just do it at their own pace, with mum helping gently and guiding. You both work together, and no one else touching preferably. And then the baby reaches a level of satisfaction after feeding off both breasts for about two, maybe 3 hours. Sometimes it's not continuous feeding over that time. It's a very leisurely time. In that time, the baby draws down, draws down the colostrum, And then all the ductal networks are now getting ready for the increase in milk volume, which we call, and the transitional milk, the milk coming in before you reach the peak, gets ready to bring it all down through the ductal networks much easier than if there's colostrum still in the breast. So that first feed is very important to clear a lot of the colostrum through the ductal networks. Then the baby goes to sleep. Then the mother has a rest and recovers as best she can in that time. And then, you know, after the baby wakes, in my time it's well over 6 hours. In the hospital time it's much less, of course. If we could leave it longer and not disturb and just observe, it would be much better, but we don't do that. And then the baby starts feeding frequently. So when the baby wakes from the sleep, the mother will be busy for the next up to 72, 96 hours. She can't rest much in that time. She will get episodes of resting if the baby's feeding frequently from both breasts. And the baby's then stimulating hormone production, bringing the hormones into the mother's bloodstream, and then the milk comes down and she's filling the breasts slowly, gradually over the next 72 hours. Our breasts aren't full when the baby's born. The baby has to work the volume up in the breast. And that takes about three, sometimes 4 days, depending on the birth circumstances and the history. This is why history is important to me. And then you understand better. And also depending on whether the mother had any opioids in her anaesthetics, which is common with epidural and spinal and general anaesthetic, and pain relief if they've had surgery. So the opioids make the baby sleepy. So we need to be aware of that too, because some babies just don't feed properly in that time. And that's another subject that's called stimulation. So I won't cover that now. Then what happens as the milk gradually increases, you see the baby swallowing more episodes of swallowing, not working so hard to get the milk to come. You'll have episodes of stimulation and episodes of swallowing. And then you'll see the changes that go through the baby's digestive system into the nappy, and you see the poos. You see the volume of wheeze increasing, you see the volume of poos increasing, the colour and the consistency changes as the milk comes through and goes through the digestive process. Then around 72 hours the breasts are full, but if the colostrum's been moved down, you don't see that lymphatic engorgement with painful, hard, full breasts. That's what we want to try and avoid. So that's why it's important not to interrupt that 72 hours, that first 72 hours, to allow that natural, normal mammal process for the human mother and her baby to take place. Then that also reduces the risk of early mastitis, because the breasts aren't so full that you've got milk banking up and blocking. And so if there's colostrum in the breast, the transitional milk can't get through properly. So that first 72 hours is extremely important to allow the things to happen, and the baby always knows what to do, except if it's an opioid-affected baby most times, or if it's had very low APGAR scores, and that may be a different set of circumstances. Anything that's an emergency or urgent situation sometimes alters that. So then when we get to 72 hours, my suggestion through my practice, and this is working with hundreds of women at home who taught me a lot of things that I really didn't experience in the hospital system. So they took me on a journey of more learning, and that feeding from both breasts from about 72 hours, so that's using what we call the Thompson Method, feeding from one breast, time to pre-digest the milk in the stomach and rest, feeding the baby to satisfaction actually. So the baby actually knows when it's reached stomach capacity. And then when it's reached that capacity, you'll see the changes in the baby's behaviour, and you can see that on the video too. I won't go into detail in that now. Then the baby, after the rest and digest, has a nappy change. So preferably laying the baby on your knee so it can stretch out, and that middle body stretches out, and that leaves room between the diaphragm and the stomach for any air to rise and for that pre-digestion to take place comfortably. If they're sitting compressed, it's very hard on the digestive system, and it's very uncomfortable for the baby if the stomach is full. And it's a bit like us. If we've overeaten, you know, we sit like that, it's much more uncomfortable. We tend to stretch the middle body out. And then the baby activates and asks for the second breast. So that the small brain at the base of the head is active all the time because it coordinates everything the baby does. And so we need to be able to make sure that's freed up as well, that we don't hold the baby by the base of the head, along the neck and along the shoulders, over the shoulder area. So we tend to do head, base of head, along the neck, and this rests on the shoulder area. And it sets off the reflex. If you push, the baby will pull back. And you'll see that reflex, it's the Morrow reflex working. And so be aware of all of those little things that interrupt the mammal baby's ability to do what it knows what to do. And it's about survival in the species. It's really an amazing experience. Feeding from the second breast at its leisure, and then being held upright to pre-digest the milk in the to pre-digest the milk in the stomach after the second breast. And then off to sleep. The newborn and the young baby is likely, once it's reached capacity from both breasts, satisfied from both breasts. The stomach's about the size of the little hand, a closed fist, like that. And that's just an analogy to give you an idea that it's not a lot of volume, but it's enough volume for the tiny baby's stomach. And then they sleep and they go on to the next feed. So if we start off that way, it's easier to get to stimulating both breasts 7 times in 24 hours. So say roughly 3 hours down the track, the baby wakes for another feed. Start on the breast you finished on last time. So if you started on the left and finished on the right, this time you'd start on the right and finish on the left. And that keeps the volume production up. It keeps everything working in sequence. If you use one breast, eventually the other breast is not being used as much. You start to reduce the volume because the capacity in the breast is always full. If the breast that the baby's going to is always full. So there's a message to the pituitary gland to slow down because it's a high production. And then already one's slowing down. So it's a cycle. So if you can imagine the cycle, keep the cycle working. And in the long term, if you can keep that rhythm and that cycle going, again, it depends on the baby and it depends on the individual circumstances. These are just the principles. But if you understand the principles and you can keep that going, you're more likely to sustain breastfeeding longer because your production of milk is continuous. And the baby will know how many feeds it needs in 24 hours depending on the baby's growth and development, depending on the capacity of the baby's needs, and feeding volume may vary. We don't measure it, but it may vary from one feed to another. It may not be the same every feed. The baby knows what it needs to be satisfied. And of course, roughly every 3 months there's a bit of changes go on, and you just be prepared for the changes. The babies adapt to all sorts of different things over the time, teething, introduction of food, maternal contraception. All of those things create adaptation periods for the baby to deal with, smell, taste, and change in hormones. Changing in hormones temporarily slows down the milk volume sometimes, so that's a bit of a fear for some people, thinking their milk volume has slowed down. So just to reiterate, the principles are to first feed leisurely. First 72 hours, continue feeding as the baby asks for it. There'll be rest periods, but there won't be long rest periods. And if you give the baby cow's milk formula in that time, and you can avoid it, it's best to avoid it because that interrupts your production of milk and you end up with engorgement. Unless you are simulating what would happen under normal circumstances, you'll end up with breast engorgement and highly likely to end up with early mastitis as well because there's too much milk in the breast. So the baby knows what volume your volume will come up quite high and it'll be full breasts, but then it regulates by going to the two-sided feeding, so 2 breasts per feed. Then the baby wakes for feeds, and the baby will wake about 7 times in 24 hours. So if you're ready for your baby to feed and prepared, it'll take about an hour for each feed by the time you've done, the first breast, the rest in digesting periods, and the second breast. It takes about an hour to complete a feed and for the baby to begin to settle to sleep. If you can keep that cycle up 7 times in 24 hours, roughly, it might be 8, it might be, if you've got a bigger baby, it might be 6. It just depends on what the individual circumstances are. then that cycle and that rhythm is what keeps the pituitary gland functioning, keeps it producing the hormones that are required for milk production, and you are less likely to run into problems. There'll always be, changes going on, and if you deal with those changes as they come, it's not so hard to do. So I'm sure there'll be a number of women out there who have experienced this and have done this, where you just... And then some people keep feeding all day and don't feed at night. Well, that just interrupts the pituitary cycle. So, frequent feeding during the day causes a lot of bellyache, a lot of tummy ache, a lot of wind, and then a long period overnight where the baby's had been filled up so much during the day, doesn't feed at night, that then increases or it decreases prolactin and oxytocin, and then the hormones progesterone and estrogen rise, so you're more likely to menstruate earlier, or at least ovulate early, maybe not menstruate. Some women ovulate before they actually menstruate for some time. You don't always get menstruated, but that then changes the whole perspective. So the principle is to keep the cycle going in the rhythm of the baby. So we're working with the baby's needs, what the baby's caloric and volume needs are, what the fluid needs are for the baby, and the baby knows that. And as the baby grows, the stomach grows too. So then they increase the milk volume as they feed to meet those needs. And as they get bigger, they'll drop back to 6 feeds, to 5 feeds. When they're introduced to foods, they'll probably drop back a feed or two, so that they're regulating their calorie and their volume intake themselves, but that means that they don't need as much milk. So the principle is that they have food and then they have a little drink, have a cup of tea. So it's breast milk, of course, but that's the analogy that I use. I hope that helps understand how important it is from the very first feed right through the breastfeeding history to work with the baby, and the baby will always know, and your instincts will also guide you. So most of all, take care of yourself, get help. Oh, we've got some questions, I'm told. Thanks.
From Ashley, is it true that water and food intake affects milk volume?
Ashley's asking, is it true that food and water intake affects volume? If you were dehydrated, that might be that you'd need fluids, right? That may be. Food intake, if you are hungry, may affect volume. If you're not getting enough food and you're not nourishing yourself or not able to nourish yourself, you're in poor conditions, then that may affect your volume. And then that becomes also a vicious cycle, because you end up feeling stressed, feeling sick, and then it becomes a vicious cycle. So that can affect you, but generally healthy foods and drinking to thirst, eating to hunger, drinking to thirst, eating foods that are nourishing for you, it doesn't affect your unless there's a known family history of allergy to something, then you either keep that low or eliminate it depending on the individual history. So I hope that answers that question for you.
I've tried, this is from Melissa. I've tried Metillium, fenugreek and lactation cookies and still don't seem to have enough.
Yeah, so this is Melissa's tried lactation cookies, fenugreek and Metillium. None of those things make milk. And it's really sad, because I was in IGA the other day and there's a packet sitting there which says cookies for mother's milk, and I read the label and it's got flour and all these things in it. I should have photographed the label actually, because they don't make milk. They may temporarily nourish you. The Metillium is an anti-vomiting drug, and it does have some effect on the pituitary gland, which may temporarily increase milk volume, but once you can't be on it forever. So what increases milk volume is the stimulation of prolactin and oxytocin from your pituitary gland. And to get that right means that the baby needs to be using the oral cavity to full potential. So cradling the baby, not forcing the baby onto the breast, not holding the baby by the back of the head, neck and shoulders. Because when you hold the baby by the head, neck and shoulders, you prevent the small brain allowing the baby to coordinate what it does. You're controlling, you're restricting. And I see other people doing it. as well, not just the mother, other people do it as well. And when you put the nipple to the nose, the nipple's heading up to the roof of the mouth, and the baby has to pull right back to be able to get on it. And then the theory is you get more breast tissue in the mouth, but you imagine having a lump of meat pushed into your mouth, you can't do anything with it. So what the baby needs to do is to activate the vacuum system inside the mouth. So it's so important not to hold the baby by the base of the head, neck or shoulders. When you've got the neck restricted, the baby can't turn. So that's, again, the coordination of what the baby needs to do. It needs to activate all its limbs, its hands, its sensory organs, smell, taste, touch. It touches the breast, it locates the breast. So every time we do that, we interfere with the small brain, and we also interfere with the first two vertebrae, the atlas and axis, and then the heel of the hand rests around the seventh vertebrae, which sets off the brachial plexus, which means the baby, it stimulates the Moro reflex, and so the babies actually pull back, and especially when there's force. And when there's force, if you can imagine someone grabbing you by that area of your head every time you go to eat and shove you to your dinner plate, what would your reaction be? It's not meant to be. Mother Nature didn't meant our babies to be fed like that. And the reason I feel confident about that is because of my research. And when we changed that, it made an enormous difference to nipple trauma, to breast engorgement, and to early mastitis. So I think just keeping it so that the mammal baby knows what to do, you know what to do as the mammal mother too. You absolutely know what to do. It's just you get overwhelmed with information. Giving cow's milk right in that first 72 hours does cause problems. It causes problems because the baby gets filled up with the cow's milk, then doesn't drink your milk, and then you get the backlog going on. So I hope that answers. Does that cover everything?
Well, that was for Melissa.
Yeah, Melissa, all that stuff, you can take it if you want to. I don't say don't take it, but I say if you do. Hi, Kylie. How nice to see you. Oh, no, you're there. It's really important to know that they are like Band-Aids. They don't actually change the pituitary function. Only the baby who's drawing your breast to full potential and stimulating both breasts each feed can do that in a cycle, in a regulated way. So I hope that helps.
This from Chloe. I'm having a C-section on Wednesday. Will it take longer for my milk to come in than a natural birth?
So Chloe says having a C-section on Wednesday, and she wants to know if it'll take longer for her milk to come in. Hopefully not, Chloe. If you get your team making sure that your baby comes from your uterus, once the incision's done and the baby comes to you, preferably not taken unless it needs to. If the baby's fine, the baby doesn't need to be taken away. The baby needs to come to you. So the team around you, especially the midwife, will know that the baby's APGAR scores are okay, and the baby comes to you, and the baby needs time just to settle with you, and they're observing the colour of the baby's lips, they're observing the baby's activity, they're observing the baby as it starts to transition to crying. And so all of those observations are going on. It depends on the drugs you've had, and if you've had fentanyl in an epidural, it's highly likely your baby's going to be sleepy over that next 72 hours. So my suggestion to you is to make sure you get your baby coming to you straight away, that your baby's using sensory skills straight away, smelling, tasting, touching. As soon as it's ready, it's doing that. And we do see that happen. And then the baby will be trying to locate the breast. If the baby's starting to show signs of being sleepy on and off, when it comes to the breast, wants to feed but then drifts off to sleep, then you need to start simulating. And there is information in some of my video clips about simulation. So I would start being prepared for simulation from the beginning so that you're well in advance if you need to do it. So if you could have a look at that, that would be really helpful.
Maybe the newborn course would be good.
And the newborn course? Yeah, of course. Marie's just reminded me there's the newborn course as well, and that will give you lots of information too. But it's hard for you because you're there having the surgery, so there's not a lot you can do. But if you get your team to think about it's your baby, and we need, if APGAR scores are fine and this baby's fine and your history's been okay, then your baby comes to you. That's the most important. We have to learn not to separate. And, rubbing the baby hard to dry it, all of that needn't happen. All you do is have your baby here and cover it with a nice warm wrap. They'll cover it for you. You won't do that, of course. And they'll cover it for you. That absorbs the moisture off the baby, because we want the baby to be skin to skin with you to start getting all your microbes. So your microbes are preparing your baby's gut. When it sucks its fingers, when it rubs its nose, when it licks with its little tongue or touches your nipple, it's getting microbes from your body, which is so important for the preparation of the baby's gut. So if you can ask for those sort of things, maybe put it in writing if that's what you want to do, and ask the team to respect your wishes as best they possibly can. Of course, under urgent or emergency situations, that doesn't happen, but as soon as possible, it's better for your baby to be with you, beside, like close to you, and preferably on your body. I hope that helps.
Another one, do I need to pump at work to keep my breast milk supply up? I appear to have a drop when I didn't express it well.
Yeah, so next one is from
Ilmea.
Ilmea, do I need to pump at work to keep my volume up? Yes, Ilmea, I would encourage you to try and, if you can, I don't know where you work or what your working system is like, but if you can roughly pump when you know your baby's going to feed while it's with whoever's looking after it, that will keep that rhythmical cycle going. If you don't pump over that time, the risk is you get too much milk in your breast and you can end up with engorgement and mastitis. And also it interrupts the cycle. So if your baby's going to feed once or twice while you're away, maybe 3 times, I don't know, it's better if you can express. And if you can't do it that many times, make it as close to and as much as that you can do, but to continue the cycle. So you don't want a great big gap. You're better off to come here and express and then wait a while and then, a little bit down the track if that's the way. But it depends, again, on your circumstances. But if that cycle that I've just talked about, if you try and maintain that, depending on how old your baby is and what your baby's doing at that point in time in feeding, and you'll know, and then when you come home, you feed your baby and you feed your baby through the night, it should work out for you. A lot of women do it that way. Hope that helps too.
Last question from Catherine. In the first 24 hours after that first feed, the babies I have seen tend to not wake regularly, and if woken, still won't feed after 24 hours.
From Catherine, yes. Catherine, in that 24 hours after birth, is it?
Mm.
Yeah, in the 24 hours after birth. That depends if the baby does have the first feed or not. And also if the baby is opioid affected. So if the mother's had opiates, the baby's highly likely in that time to be now being affected from the transfer of opioids through the placental flow and then now through the milk because it's in the maternal bloodstream. So that will make a difference to how your baby's waking. So it's really important that your baby is fed in a simulated way, either by a syringe or preferably not a teat, because once you start introducing a teat, the babies are gravity fed, and then what happens is they don't want to go back to the breast, or it's difficult for them to go back to the breast because the teat is a different mechanism altogether than the breast tissue. Having your baby close to you as much as possible, letting your baby start to awaken to use the skills to come down to your breast by itself. It may not feed, but it's keeping those sensory skills awake. That's really important, and activating them. So the baby activates those sensory skills because once it's here, it knows how to come down to your breast. It actually moves with its arms and legs. All those small brain coordination takes place, and it works its way to your breast and it turns its head. And so then just keep your baby close to you as much as possible. Keep your baby fed. And they say roughly every 3 hours, but 3 to 3.5 hours. But watch your baby's behaviour, and it depends whether the baby's with you or whether the baby's in the nursery, all of those things. But we're still aiming for 7 feeds in 24 hours and only feeding till the baby's satisfied, not overloading the baby's stomach so that they start vomiting as well. That's feeding the baby to satisfaction is watching the baby's cues, and the baby will always give you the cues when it's had enough, except if it's an opioid affected baby, it will be drowsy and sleepy, so you're better off to give a volume of milk via the syringe on the regular intervals so that that milk starts to break down the drugs. And as it breaks down the drugs, it passes it out through the urine and bowel system. So baby will be excreting that via the milk, and preferably your milk, not cow's milk. I hope that one helps too.
That's it.
Thank you. Thank you for joining us.